Thank you, sir. It's a pleasure to introduce the next speaker on a topic which is also very common of neonatal seizures. It will be presented by Professor Irfan Waheed. Professor Khaja Irfan Waheed is the head of the Department of Neonatology at the Children's Hospital Lahore. He is supervisor and examiner of CPSP in the subject of pediatrics as well as neonatology. He is the founder member and director of the Neonatal Life Support course and many other neonatology courses conducted regularly by the Institute of Child Health. He is also a lead facilitator, neonatal training and country contact of the American Association Academy of Pediatrics for Helping Baby Breathe. He is a member of the Provincial Technical Working Group on Newborn Care for the Government of Punjab, author of many books, reviewer of many journals. We welcome Professor Khaja Waheed, Irfan Waheed, for his talk on neonatal seizures. And as I must add to the formal introduction that he is the Ruhe Rawa of all this conference. So thank you very much and congratulations on this successful event.
Thank you very much, sir. After listening to Professor Huck's presentation, I was wondering, it's on, sir, I think they have to turn it on. Is it okay? While I was listening to Professor Huck's presentation, all the time I was thinking, okay, what a marvelous creation a human brain is. What a marvelous creation. And all the more importance of breast milk in developing brain. And also I was thinking it will be very difficult to talk after Professor Huck. Very thankful to my scientific committee for giving me a topic that is probably one of the most common presentations in our neonatal emergency, and that is neonatal seizures. Outline of my talk is that first I will introduce a little bit about neonatal seizures, some definitions, what are the types of seizures, how can we diagnose them according to the latest classification, and stepwise approach to the management of seizures. It's such a huge topic that it cannot be, all of it cannot be covered, but I will try to summarize as much as I can. It is one of the most common manifestation, neonatal seizures, of neurological dysfunction in neonates, and it is very different, it presents very differently in neonates as compared to older children. Out of every 1,000 live births in a very low birth preterm babies, 58 babies they present with seizures, while in term babies, only about 2-3 babies out of 1,000 live births of term babies, they present with seizures. If the seizures are not controlled, they lead to secondary brain injury, and the outcomes in newborn, those who present with seizures, are not as good as they are in older children. Let's start. What is a neonatal seizure? Seizure is defined as a sudden alteration in behavioral, motor, or autonomic functions due to abnormal, excessive, or synchronous neuronal activity in the brain, which is manifested as uncontrollable jerking movements of arms and legs, maybe like a staring spell, loss of consciousness, or abnormal movements. And epileptic seizures are those. They are broadly divided into epileptic and non-epileptic. So epileptic seizure is the one which has a simultaneous presence of an EEG positive. And by what I mean by EEG positive is that the amplitude of an EEG, there are certain jerks, amplitude should be at least 2 millivolts, and the duration should be more than 10 seconds. That is an positive EEG positive electrographic seizure. There should be at least 2 unprovoked seizures during 24 hours, or 1 unprovoked seizure and a probability of further seizure similar to the general recurrence risk after 2 unprovoked seizures, or a diagnosis of epilepsy syndrome. I will explain later what's an epilepsy syndrome. They are classified as epileptic seizure. while a non-epileptic seizure is a paroxysmal event that appears similar to an epileptic seizure, but they do not involve abnormal EEG. So EEG is normal in a non-epileptic seizure, although they present like seizures. I have used the latest classification of ILAE, International League Against Epilepsy, which was published about a month back. And they have based the classification of seizures according to, and they have recommended that it should be based on EEG findings. A baby who presents critical ill or has a clinical suspicion of seizure should undergo an EEG. There are two possibilities: either the EEG will be positive, in that case they are epileptic seizures, or they may not be an EEG positive seizure, in that case it will be a non-epileptic seizure. The epileptic seizures with EEG correlate can present clinically, or they may not be any clinical presentation and there will be only electrographic, and those are detected only on EEG. The electroclinical seizures are then further subdivided into motor, non-motor, sequential and unclassified seizures. I'll explain a little bit about these types of seizures. Types of motor seizures, they are then further divided according to the ILE classification, and it's a changed classification from the previous one, into automatism, which previously were known as subtle seizures. Clonic seizures now are divided only into focal, multifocal and bilateral. Previously there was a term also used as generalized, but now they have seen that generalized seizures also start as focal seizures, so the word of generalized has been taken out. Other types of motor seizures, they include epileptic spasms, myoclonic and tonic with their further subtypes. Other types of seizures are non-motor, and they are further subdivided into autonomic and behavior arrest. And the last type is called sequential. I'll explain later one by one these types of seizures. Automatism is a coordinated motor activity. I don't think I can see the video on this. So first type is this automatism, which is a coordinated motor activity and that resembles voluntary movement in newborn babies. Often it's a part of sequential seizures, and it is generally manifested as movements from oral, buccal or lingual areas. Clonic are repetitive rhythmic contractions of muscle groups of the limbs, face or trunk. There is a rapid flexion phase followed by slow return, and they may be unifocal or multifocal and may occur synchronously or asynchronously in muscle groups on one side of the body or asynchronously on both sides, and they cannot be suppressed by a restraint. Epileptic spasm is another type of seizure. Although they are rare, they involve sudden flexion, extension or mixed extension flexion of proximal and truncal muscles. They are more sustained than myoclonic but less sustained than tonic, and they may occur in clusters. Examples are grimaces, head nodding, subtle eye movements. Myoclonic seizures are random, single, rapid contractions of muscle groups of the limbs, face or trunk. Their duration is less than 100 milliseconds. They are typically not repetitive or may recur at slow rate, but can be provoked by stimulation, and they may reflect injuries at multiple levels of central nervous system. There is also a benign form which is generally known as sleep myoclonus of the newborn. Tonic seizures are sustained flexion or extension of single limbs or sustained asymmetric posturing of the trunk, sustained eye deviation, and they cannot be provoked by stimulation or suppressed by restraint. Autonomic seizures are also rare. There is a distinct alteration of autonomic nervous system function involving cardiovascular, pupillary, gastrointestinal, vasomotor or thermoregulatory function, and it can also manifest as apnea or sweating. Behavioral arrest or behavior arrest is also a rare form. It is just like freezing of whatever the baby was doing at that time, the baby just freezes. And this may also be seen as a part of sequential seizures. So what are sequential seizures? They are a sequence of several seizures manifestation within a single episode of seizure. They are generally seen in genetic epilepsies For example, in self-limited neonatal epilepsy or KCNQ2 encephalopathy. There is another form which are non-clinical. There are no clinical manifestations as such, only electrographic. You suspect them, take an EEG, you find positive ECG, and they are called electrographic only seizures, and they are real seizures also. They are often seen in HIE, preterm and critically ill neonates, and are without clinical manifestation. There is another group, unclassified seizures, the seizures which do not fit in any of the known types because of lack of information. There are multiple causes of all these seizures, but the most common is hypoxia ischemia. And there is a considerable overlap between the different types of seizures which a baby can present with in different types. Hypoglycemia, hypocalcemia, and number of other causes can also cause seizures. I will not like to go into the details of each and every type. Now, I would also specifically like to mention another term which is neonatal epilepsy syndromes. These are a complex of typical features of a seizure that includes age of onset, type of seizure, signs, symptoms, and EEG finding that together define a distinctive, recognizable clinical disorder. The examples are self-limited neonatal epilepsy. Previously, according to the previous classification, it was known as benign familial neonatal epilepsy. And another type of neonatal epilepsy syndrome is early infantile development and epileptic encephalopathy. According to the previous classification, it was known as early myoclonic encephalopathy and early infantile epileptic encephalopathy or Otohara syndrome. There are certain non-epileptic movements. The commonest are jitteriness. There is equal flexion and extension phases. Baby may be alert or hyper alert. There is passive flexion. If it is done, it diminishes or eliminates the movement, and they can be spontaneous or provoked by tactile stimuli. There are no EEG changes in DC and jitteriness. Neonatal sleep myoclonus, if you can see again, it is only seen, these are myoclonic jerks only seen during sleep and does not cause any damage. EEG also is negative in them. Certain other types of movements which can mimic seizures are neonatal dyskinesias in the form of dystonia and chorioathetosis, and these are caused by damage to the basal ganglia or extrapyramidal tracts. The problem in diagnosing or labeling neonatal seizures in newborn is that the multiple prenatal or neonatal conditions with variable times of onset and duration can present with seizures in different ways. Neonatal seizures are not disease specific. They are generally very brief and settled and would not give you enough time to explain a type of seizure. Their unusual behaviors are difficult to recognize and classify in newborns, unlike adults. And generally, all of it is based on clinical observation, and there is a lot of variability in how we explain a type of seizure, a type of movement. So it is not easy to diagnose a type of seizure in a newborn. The diagnosis of a seizure is again based typically on our conventional teaching. History is extremely important and examination. Certain investigations, but the gold standard is EEG. May it be conventional, video, or amplitude integrated. Other tests are also done to rule out the other causes of neonatal seizures. WHO states that all types of seizures should be treated, but there is another catch that, like Professor Huck mentioned, the undue treatment of neonatal seizures can lead to damage if it wasn't required. So the goal of our treatment is the elimination of electrical seizure activity. That's the basic goal. EEG must be negative if we have to give, after giving the treatment. So first we need exact diagnosis. The general management principles are the same, and then are anticonvulsants, which is the mainstay of epileptic seizures. Phenobarbital still is the drug of first choice in neonatal seizure, which is recommended also. This is the most important question. When to start anticonvulsant? Previously, it used to be said that a seizure of more than 3 minutes duration or more than 2 seizures in an hour, or more than so many seizures in 6 hours, then we should start anticonvulsant. But the latest recommendation is a seizure burden of more than 30 to 60 seconds per hour is an indication to start an anti-epileptic drug. And here again lies the importance of EEG. We cannot determine the time without the help of EEG. Now I will state the steps of management that should be undertaken and a guideline. A neonate who presents with seizures fulfilling the criteria to initiate anticonvulsant therapy, initially general measures should be taken like temperature, fluids, etc., blood sugar thing. Then first drug to be used is phenobarbital, should be given in 20 milligram per kg over 10 to 15 minutes. There are two possibilities then. Either a seizure will settle, and in that case, that baby should be started on maintenance dose. But if the seizure persists or recur, we need to reload again with 10 milligram per kg. Or we also can take the blood level, which should not be more than 40. If the seizures clinically, if there are then two possibilities, either the seizure will settle, and in that case we will start maintenance. But if the seizures persist even after giving a maximum dose of 40 milligram per kg, then we need to give phenytoin in a loading dose of 20. Again, two possibilities. If the seizures settle, then the maintenance is started in a combination of phenobarbital and phenytoin. But if the seizures persist or recur, we have to reload once with phenytoin with 10 milligram per kg. Then after that, if the seizures settle, the maintenance need to be started after 12 hours. But if the seizures persist or recur, the next drug is to be used is levetiracetam in a loading dose of 10 milligram per kg. After levi is given, if the seizures settle, maintenance is started with all three drugs. But if the seizures persist, the next drug that is recommended is pyridoxine, which is given in infusion form under monitoring of EEG. If the seizures they settle, you very well know that that baby requires pyridoxine for rest of his life. But if the seizures persist or recur, that is the place to use midazolam. As Professor Herc also mentioned, midazolam is not that safe a drug that was considered previously. At the same time, that baby needs to be prepared for mechanical ventilation. After the midazolam infusion is started, if the seizures they settle, midazolam infusion is continued till more than 24 hours of normal EEG period. And then the maintenance, it's tapered down and maintenance is started with all previous three drugs. If the seizures persist, then other anticonvulsants like lidocaine or topiramate can be considered. But I think that's the line where we draw between a neonatologist and a pediatric neurologist, and that's the time that we need help of pediatric neurologist. It's very easy to start an anticonvulsant, but they have their side effects. When to stop them? That's a very tricky question. First, it should be the rule that if the baby has to be discharged on one anticonvulsant, when the seizures are settled, we gradually take off one anticonvulsant in turn, gradually till and the baby is seizure free until only one is left, which is generally phenobarbital is the last one to be taken off. If the seizures are controlled for more than 72 hours on phenobarbital, then the baby is examined neurologically, and by neurological examine I mean clinical plus EEG, not only clinical. If there is no neurological abnormality, that means clinical and EEG is normal, anticonvulsant can be stopped straight away. But if there is a deficiency in either EEG or there is in clinical, then phenobarbital is continued for 1 month. And if then after that, if there is no neurological abnormality, we have to taper down phenobarbital over 2 weeks. But if the neurological exam is not normal even after 1 month, then phenobarbital is continued for 3 months and then reassessed again. In case of normal neurological exam, again phenobarbital is taken off gradually. But in case of abnormal neurological exam, even after giving phenobarbital for 3 months, that is the line where the line of neonatologist ends, and we should refer the baby to a pediatric neurologist. So what is the prognosis of such babies? It depends, of course, depends upon gestational age. Lower the age is, higher is the risk, worse is the outcome, longer are the problem. It also depends upon the severity, underlying etiology, and the EEG pattern of the. About 15% of the babies having seizures, they die, but generally they do not die because of seizures, but because of the underlying problem they have. Morbidity associated is 30% of the babies. 20% of the babies of EEG confirmed cases, they develop epilepsy by 1 year of age. 6% of them will develop cerebral palsy, 18% will develop intellectual impairment, and cerebral palsy and intellectual impairment combined is found in 45% of the EEG confirmed cases. So in summary, epileptic seizures represent serious underlying neurological dysfunction. They manifest differently in neonates. EEG is the gold standard for their diagnosis, and uncontrolled seizures can lead to secondary brain injury and must be prevented. Timely management is important in preventing long-term morbidity. Thank you very much for